K flat, K mean, and the K steep depicted no progression or significant change during the pre-op and the 3-month post-op period. So our study suggests there is significant improvement in the UCVA and spherical equivalent, which is similar to previously reported data by Kamya et al., evidencing a significant increase in astigmatism, significant decrease in astigmatism after toric eye implantation in 19 eyes with mild keratoconus. In our study, the keratometry parameters also did not show any statistical significant variation between post-operative visits, which were in agreement with previous reports by AIOC et al., which included 17 patients with a minimum follow-up of 12 months. So to conclude, toric intraocular lens implantation in corneal ectasia patients with cataracts constitute a safe and efficient tool for visual rehabilitation with good refractive outcomes and predictability, and successfully negotiating challenges like recognizing patterns on anti-sagittal map in the visual axis and accurate IL-PAR calculation will provide better visual outcome even in patients with advanced ectasia. Thank you.
Thank you, Dr. Sujit. So, any questions from our chairpersons?
You have to follow only for 12 months. Angelo?
No, 3 months. 3 months. We are continuing it as the patients increase, and we'll monitor the patients for 12 months. We are planning for 12 months, but currently we have the data for only 3 months of those patients.
But you people are satisfied with this outcome?
Yes, sir. Actually, a few patients
The readings are same.
Yes, sir.
Readings are same.
Yes, sir. There is significant increase in the UCV and BCV, and the keratometry readings are not changing. So it's stable with a good predictability outcome.
Thank you. Good.
Thank you, sir.
This IOL-Master 700, you use the K readings from Topo or
No, K readings are taken from the Topo, sir. IOL-Master we use for the formula, Barrett 2 formula. K readings are entered from the Topo.
Were they significantly different?
So even if in all patients they were used from the Topo.
Have you found a difference in
No,
Topo
sir.
and
No, sir. No major difference in the keratometry findings in the Topo and the IOL-Master 700. So
and most 7 cases, huh?
yes, 6 cases till now. We are all, thank you, sir.
Next, do we have Dr. Varsha Wilson over here? Yeah. She'll be presenting on heparinized irrigation fluid versus heparinized PCIOL on post-op inflammation after cataract surgery. Seconds. Membership number.
Good morning. The title of my paper is Heparinized Irrigation Fluid versus Heparinized Posterior Chamber Intraocular Lens on Postoperative Inflammation After Cataract Surgery. Diabetic patients with cataract develop more severe postoperative inflammation as diabetic retinopathy causes a more severe blood-aqueous barrier breakdown. The breakdown after cataract surgery is a result of trauma and of immunological reaction that causes protein leakage into the aqueous humor. The type of surgery and the implanted IOL influence the degree of breakdown and the postoperative inflammation. Heparin has well-established anticoagulant and anti-inflammatory and antiproliferative effects. Heparin surface modification leads to prevention of bacteria, protein, and lens epithelial cells attachment to the IOL surface. It also restricts the growth of fibroblast, microphage, and induces less granulocyte activation and platelet adhesion. Studies have concluded that adding heparin sodium to the infusion solution during small incision cataract surgery induces inflammation in the early postoperative period. As PMMA IOLs were replaced by newer foldable materials such as silicone and acrylates, the use of heparin coating has reduced. Small incision cataract surgery and foldable IOLs have significantly reduced surgical trauma, resulting in less postoperative inflammation. But the inflammatory reaction is still an issue in patients with uveitis, diabetes, and pseudoexfoliation syndrome. The aim of this study was to evaluate the anti-inflammatory effect of heparin added to the irrigation fluid and compare it to the results of heparin surface modified foldable hydrophobic acrylic PCIOL after cataract surgery in diabetic patients. The comparative prospective study was conducted in the ophthalmology department of a tertiary care hospital. A total of 50 patients were divided into 2 groups randomly. Group 1 consisted of patients who underwent phaco with the addition of 10 international units per ml of heparin injected into the balanced salt solution, and Group 2 included patients who underwent phaco with the surface modified PCIOL implantation. Our inclusion criteria was patients with visually significant cataract with type 2 diabetes mellitus with or without diabetic retinopathic changes. Our exclusion criteria included pediatric, congenital, traumatic and complicated cataract, patients with history of ocular trauma, patients having bleeding tendencies, and patients on systemic therapy with anti-inflammatory agents. All patients fulfilling our criteria underwent a detailed ophthalmic examination. The surgical technique of phacoemulsification was standardized for all surgeries. Post-operative evaluation of anterior chamber cells and flare were graded according to Sun classification, and iris pigments and cells on the intraocular lens was examined semi-quantitatively using a beam 3 into 2 mm and focused on 5 regions on the intraocular lens surface, and the average calculated. The results were compared between the two groups on post-operative day 1, 1 week and 4 weeks post-operatively. Coming to the results, the baseline characteristic of group 1 and group 2 showed no significant difference in terms of age, gender, and duration of diabetes between the two groups. Coming to AC cells, there was a statistically significant reduction in AC cells post-operatively on day 1 and day 7 in group 2, which is a HSM PCIOL group. And following a similar trend, AC flare also showed a statistical significant reduction in group 2 on day 1 and day 7. Iris pigments also showed a reduction in post-operative pigment dispersion, which was statistically significant on post-operative day 1 in group 2, and day 7 and day 28 showed no difference. The use of heparin in ophthalmic surgery was first described by Johnson and co-authors, who found that a single anterior chamber injection or heparin supplementation in the infusion solution or a single intravenous injection resulted in statistically significant reduction in post-operative intraocular fibrin formation. Larison et al. Demonstrated in vitro the improved biocompatibility of heparin surface modified lens with respect to outgrowth of fibroblast, macrophage, and activation of granulocytes and adhesion of platelets. These results were subsequently verified in vivo in terms of less inflammatory cells on the lens surface and fewer incidences of synechiae in the rabbit eye. Several studies have shown heparin surface modified PMMA IOLs have caused less inflammation than unmodified PMMA lenses. Heparin sodium added to the standard irrigation solution reduces disturbances of the blood-aqueous barrier in the early postoperative period. There seemed to be no long-term effect, especially on cellular reaction and on the hydrophilic IOL surface. As heparin is proved to reduce inflammation and complications in pediatric cataract, diabetes, uveitis, pigment dispersion, and pseudoexfoliation glaucoma, adding heparin in the irrigation fluid or using a heparin surface modified PCIOL in these cases that are predisposed to enhance postoperative inflammatory response is a simple, effective, and safe modification that can be used in routine cataract surgeries. Coming to the conclusion, our study has found that heparinized irrigation fluid used along with acrylic hydrophobic PCIOL is not as effective as heparin surface modified acrylic hydrophobic PCIOL in reducing early postoperative inflammation. However, by day 28, the results were the same in both groups. The long-term effects of decrease in pigment deposits on the intraocular lens surface has also been demonstrated. Thank you.
Thank you, Dr. Varsha.
So, I see that you are not a ratified member.
No, ma'am. I'm a postgraduate, ma'am. Third.
Okay, so this paper will not be considered for award.
Do we have the next speaker, Dr. Tavish Gupta, out here? Yeah. So I invite you to speak on your topic, the hammock, an innovative surgical approach for IOL dislocation.
Good morning. I'm Dr. Tavish Gupta and I'll be presenting the hammock, an innovative surgical approach for IOL dislocation. So whenever we are faced with the complications in cataract surgery, such as an anterior capsular extension or posterior capsular rent, a rigid PMMA lens in the ciliary circus has always been a viable option, and it has been shown that the visual outcomes are on par with conventional foldable single-piece IOLs. But a problem with these PMMA IOLs is of IOL dislocation, which has been shown to occur in 0.2 to 2% cases, and it can lead to various symptoms such as decreased visual acuity, diplopia, and varying dysphotopsias. Why does this occur? This occurs a lot of the times due to trauma, and it can also occur due to capsular phimosis, which causes shrinkage of the capsular bag, and it can also occur due to zonular weakening, which may be due to progressive conditions or maybe due to intraoperative zonular damage. So the management options: if the patient is asymptomatic and the lens is stable, then we can do a refraction and prescribe glasses, adopting a conservative approach. In cases in which the patient is symptomatic and the IOL is decentered, but there is adequate support from the zonules and the capsule, then we can just refixate and reposition the IOL. But if there is zonular dehiscence or there is inadequate capsular support, then we have to explant the PMMA IOL, and in such cases we exchange it with a 3-piece IOL, which can be fixated into the sulcus or into the sclera. Now, just merely repositioning the lens on the capsular remnants will lead to instability, and it can cause further dislocation of the lens. So, in case of multi-piece IOL, this instability can be countered by an optic capture, or in some cases a reverse optic capture, which provides anchorage. And in foldable IOLs also, we can do a reverse capture. But in PMMA IOLs, this becomes unfeasible due to the rigidity of the material. So, we have adopted the hammock technique, in which we tuck in the inferior part of the optic beneath the capsular remnants, and then we use the haptics, and we leverage the haptics as the strings of a hammock to provide stability and anchorage to the IOL. So this not only provides stability, but it also prevents against dislocation of the IOL against the forces of gravity when the patient assumes an upright position. And another added advantage is that because the haptics are placed in front of the ciliary zonular plane, it helps in creating an effect. It helps in reducing the shifts in the effective lens position post-operatively, and which helps in having a stable post-operative refraction. So the surgical steps: first, we create 2 MVR entries 170 degree apart, and we fill the anterior chamber with an cohesive OVD. Next, we introduce the Sinskey hook, and we dial the IOL into the center, into the visual axis, and then we rotate the haptics into the sulcus, or the haptics can be manually tucked into the sulcus behind the iris. Then, using a 23 gauge cutter, we do an anterior vitrectomy and a membranectomy also, which clears the visual axis and provides us with space for further manipulation. As we can see, we are clearing the visual axis, and we are providing space for further manipulation of the IOL. Now, finally, we inject OVD, and we push the optic posteriorly. So the inferior part of the optic, as you can see, the inferior part of the optic is then tucked in between the remnants of the capsule, and the haptics remain in the sulcus. After this, we replace the OVD with, here we can see that the inferior part of the optic is tucked in between the haptic, and then we remove the OVD and replace it with a BSS solution and hydrate the wounds. So again, these are the summary: initial preparation, manipulating the IOL into position using a Sinskey hook, performing an anterior vitrectomy and a membranectomy, and then doing the inferior optic capture. Now the results. We performed this procedure on 11 patients over a period of 1 year, and most of the patients had a good post-operative outcome with less than 2 diopter cylinder of post-operative refraction. Only 2 patients had a post-operative refraction of 4 and 4.5 diopter cylinder. 1 patient on follow-up had an IOL redislocation, which occurred at around 3 weeks, and for that the patient required a IOL exchange with a 3-piece IOL. And the stability of this technique was confirmed via slit lamp and OCT examinations, which are done at 3 and 6 months of follow-up period. So as you can see on the slit lamp examination, even in the presence of a capsular defect, the IOL is stable as it is positioned behind the inferior parts of the capsular remnant. So even in the presence of a capsular defect, we could still utilize the capsular remnants and provide stability to the pre-existing IOL. Again, we can see in the presence of a capsular defect, the IOL is still stable. And the same can be confirmed on OCT images, in which the IOL is stable behind the inferior part of the capsular remnants. In conclusion, this method has proven to be a reliable and effective option for stabilizing the single-piece PMMA IOLs, and it reduces the need for IOL explant and exchange. But additional research and extended follow-up periods are needed to evaluate the long-term efficacy and safety of this method. Thank you.
Thank you, Dr. Tavish. And how long was your follow-up duration in your study?
Ma'am, we had a follow-up at 3 months and 6 months for the patients.
And what you have, if you get a patient with a gross capsular defect, where you have just the IOL maybe sinking into the anterior chamber, so
Yes,
in those cases, what will you opt for?
Ma'am,
you
in those
don't-
cases,
for hammock, you need at least the entire support, the one which you are
Yes,
saying,
ma'am.
basically a sulcus fixation. It's the IOL in the sulcus. So suppose
Yes,
you
ma'am.
don't have that support, so how will you go about with those cases?
Yes, ma'am. If there is a lot of if there's lots of capsular support, like suppose more than more than 4 or 5 clock hours, then we cannot do this method. Then we'll opt for a scleral fixated IOL in those cases.
The posterior optic capture.
Yes.
It's a known thing. What is different in
So in this, in which in the even if the superior rim is not there, we can just use the inferior rim for the capture, and it will not help. It will not lead to instability. That's why, because if for posterior capture we need like a superior rim also with the inferior rim. So in this we demonstrated that like the hammock, we can use just the inferior rim and we can stabilize the IOL in the sulcus.
Okay, but it's not just the superior or the inferior rim. Everyone will agree that it's the maximum support that you can find that will support your IOL. It's not necessary that you have only the inferior rim.
Yes,
When
ma'am.
you don't have the posterior support, you need a support, like you have mentioned, okay, hammock was a good option, but it's something which is known. So we need to come out of this, okay? We need to find out something more innovative. But okay, good surgical videos and nice effort. Thank you.
Thank you, ma'am.
Is Dr. Dev Prasad Gopal here? So the next speaker is Dr. Narendra Singh Verma. So he'll be speaking on comparative analysis of SIA calculators based on vector method and polar method in cataract surgery. Over to you.
Good morning, everyone. So I present this. So this is the study which was done a few years before. They measure the mean SIA and centroid SIA of 2.8 millimeter temporal incision, phaco incision. In this study, they find out that the mean SIA is 0.5 and centroid SIA is 0.18, which is 3 times lesser than the mean SIA. So centroid SIA is lesser in magnitude. It was well documented by Dr. Saurabh Savne, who developed the SIA calculator, and it is also...
Now, the next issue that I would like to talk about is surgically induced astigmatism. Well, this is a highly controversial issue, and unfortunately, I'm not going to give you here the right answers. Rather, I want to share with you some of my thoughts and dilemmas. So, many of us tend just to use 0.5 diopters for our SIA, just arbitrarily. And the question is it acceptable? Maybe we should use a quarter of diopter instead, or maybe even 0.
So this is Dr. Abul Afia. He is saying, what should I take the value of the centroid SI in my toric calculator? Should I take it 0 or should I take it 0.5? So this is the problem. So let's see how we can solve the problem. So the SI calculator which we are having presently, they measure the SIA, mean SIA and centroid SIA. And these value, the mean SIA value is used. We know the SIA, mean SIA of our incision. Then we can take the steep incision and reduce the astigmatism. Centroid SI value is used in the toric calculator. So, but it is lesser in magnitude and misleading. So we can see this is how we are measuring the centroid SI by double angle plot. This is Dr. Warren Hill SI calculator, double angle plot. In this case, centroid SI value is 0.06, which is 3 times less than the mean SI value. If I will select these, if I operate these 2 cases, which I have marked with the arrow, in this the individual SI is 0.8. And I am taking value of centroid SI 0.06, which is 14 times lesser. So what is the use? So there is no use to put the centroid SI, take the incision SI value. Better to take 0. So this is the same problem with the this practical problem. If consider that there is 2 diopter of astigmatism in 110 degree, and my incision 2.8 millimeter temporal incision is creating 0.3 diopter of SIA. If I will take incision on the steep axis, the recommended IOL power is T3. If I will take incision temporally, the recommended power is T4. So by shifting the incision to the steep axis, I can reduce the power of the toric lens, but it is not recommended by Dr. Graham Barrett. He is saying that when you are implanting the toric lens, don't use the incision SIA to reduce the astigmatism. So don't go on the steep axis, do the OCCI or something else, some part of SIA you reduce by the incision and some part by the toric lens. So let the toric lens correct the astigmatism. So the present problem is this, that now when we take incision on the cornea, there is two type of changes. There is change in the cylindrical power and there is rotation of the steep axis. So the present SIA calculator, they measure on the cylindrical power change. They don't measure the rotation of the steep axis. So these are the vector method, problem of the vector method. I will tell you about the polar method. In vector method, we use this simple formula. This is the polar method. In polar method, the SIA measured in two components. One is which tell about how much is the SIA causing the change in the cylindrical power and how much SIA is rotating the steep axis. The vector summation of these both is same. So we developed this SIA calculator, which is free online available. Just you have to scan the QR code and we'll get access. These are the we have validated it with Dr. Warren Hill SIA calculator, which is based on vector method, and Dr. Neil Alpine SIA calculator, which is based on polar method. Now these are the interesting cases. I have operated 57 cases, 2.8 millimeter steep axis incision and 2.8 millimeter OCCI. My aim was to decrease one diopter of astigmatism when patient was not affording for toric lens. And these are the 12 cases of Dr. Deepak Meghur, who has taken incision on the temporal incision, 2.8 millimeter temporal incision. It is not on the steep axis. First one is on the steep axis. So these are results. Now these are the results. Mean SI in first group, 2.8 millimeter main incision, 2.8 millimeter OCCI is 0.77, and in 2.8 millimeter temporal incision is 0.55. So it's okay. 0.5 for 2.8 millimeter is okay, and 7 it's okay. But see this. In the group 1, the mean SIA is 0.77, out of which 72% is causing change in the cylindrical power. 28% is rotating the steep axis. While in the group 2, mainly the change in cylindrical power is only 46%, and the rotation of a steep axis is 54%. So when our incision is not on the steep axis, then the rotation of the steep axis is more as compared to the change in the cylindrical power. So this is the same thing. So what we get from the group 1, the centroid SIA, which is mean SIA is 0.77, centroid SIA 0.50. It is lesser, but it is acceptable. In group 2, which was not on the steep axis, the centroid SIA value is 0.12, which is 3-4 times less than the mean SIA. So we can predict centroid SIA value by polar method more accurately when the incision is on the steep axis. When incision is not on the steep axis, then we can't see anything. So
thank you, Dr. Verma, for the presentation. Okay, no questions for you, sir. So next speaker is Dr. Nichlani VK. So he'll be speaking on the novel approach of managing posterior polar cataract by eliciting floating sign and avoiding PCR. Over to you.
Good morning, dignitaries. I'm Dr. Paresh Nichlani, co-author. I'll be speaking on behalf of Dr. VK Nichlani. The aim is to explore the details of different characteristics of posterior polar cataract and how to avoid the dreaded complication of PCR with the novel approach of floating sign. So a pre-op examination, as we do in all the cataract surgeries, mandate, but the one in these cases is to know the anatomy and the morphology of the posterior polar cataract, the size, the onion peel appearance, halos around the posterior polar cataract, radial stretching lines, fishtail sign, and sometimes the white flaky material can be seen behind the cataract. Posterior polar cataract is known for leading cause of PCR. In varying studies, 25 to 30% have been noted. These studies establish the efficacy of floating sign in avoiding PCR and explore various details of posterior polar cataract. So total 136 cases were observed in last 26 years. The age of the patients were from 40 year to 78 year, majority of them being male, and majority of the cataract nucleus sclerosis was grade 1.
Just a clarification. In the directions, it is written that changing of presenting author is not allowed. So we cannot allow this presentation.
What is your name?
Sir, Paresh Nichlani.
Yeah, but you are neither the chief author nor the presenting author, right? So it's not allowed for this presentation.
So if you have to do this presentation, you have to take permission. That too at least 3 days prior. Or
last moment, so they have mailed, but we didn't got the.
okay, so we are so sorry you cannot present. Yeah.
I don't mark it, I'll just present.
Okay, but will not be scoring. You can
Yes,
just
yes,
present your
definitely.
presentation at the time.
Thank you, ma'am. So the exclusion for these cataract were any pre-operative posterior capsular dehiscence which were observed on slit lamp examination. So these were the observation. Never touch the posterior plaque with phaco tip because it can lead to sudden suction and you can end up in a posterior capsular rupture. When there is a thick hard cataract and it is difficult to separate the nucleus from the epinucleus, so never try much of a rotation of your nucleus or you can land up in this situation. Always avoid active pulling or pushing of the last epinuclear plate or the cortex, which can lead to posterior capsular dehiscence, as you can see here. Never ever try to polish the zone where the posterior plaque was present, because the posterior capsule there is already weak and it can lead to dehiscence. So what we learned using this floating sign is that first clear up the cortex without doing any hydro procedure, and at the level of the nucleus do hydro delineation and separate the nucleus from the posterior cortex of the posterior epinuclear plate. Then manage this nucleus like we do in a normal phacosurgery. Just keep few things in mind, that your AC should never decompensate. The nucleus should not be rotated very aggressively or vigorously. And once you have cleared up this central nucleus, then there is good amount of space in your capsular bag. So now take, after managing the nucleus, take your irrigating port just at the plane between the anterior capsule and the cortex, and with this passive hydration the fluid gush goes at the level of the plaque, and because there is much space anteriorly, the capsular bag is already empty. The force which is generated at that level pushes the plaque upwards rather than pushing the weak posterior capsular bag for dehiscence, and this we have named as a floating sign. So again, to demonstrate the same sign, after managing the nucleus, just do this active hydration passively. So what happens, again I'll explain, this active fluid goes at between the posterior capsule and the cortex, and it lifts up the capsule because there is enough space anteriorly. So with this technique, out of all the cases, we had only 2 posterior capsule rupture, and those cataract were also a grade 4 cataract. So as I have explained in the video, posterior capsule is weak at the level of plaque but not deficit in all cases. The hydro dissection in such cases allow the weak plaque area to give away, as the wave could not move further because the bag is already occupied with the nucleus. But when the bag is emptied of the nucleus, the resistance decreases as shown in figure 2, and with a good passive hydration, there is no active force on the posterior plaque. With the passive hydration, the weak area does not go posteriorly but it floats the plaque anteriorly, and hence preventing the posterior capsular rupture.
Okay, thank you,
Thank
Dr.
you.
Paresh.
Thank you,
That
ma'am.
was indeed a good presentation, and hope you come up as the presenting author for the next AIOC.
Sure, ma'am.
Best wishes. Thank you. So next we have Professor Major General J.K. Parihar sir. He'll be speaking on comparison of functional outcomes between flex and MICS in post-radial keratotomy cataract.
Thank you, ma'am. Post-radial keratotomy eyes poses a big challenge. One is with the calculation of IUL power, and second is the intraoperative decisions and unstable anterior chamber. With this aim, we have analyzed the pattern and compared the functional outcome between flex and conventional phaco in post-RK cases. We have retrospectively studied 70 eyes, of which 38 eyes had undergone flex with toric IUL. Amongst the 70 eyes, RK cuts were as follows. Maximum 34 eyes had 12 cuts, and 22 eyes having 16, and remaining 14 eyes had 8 cuts. Preoperative astigmatism was ranged from plus minus 2 diopter to 5.5 diopter in both the groups. A moderate nuclear grading in all cases except one case of hypermature cataract, and our follow-up period was ranged from 6 months to 2 years. The statistical analysis was carried out on SPSS software by a qualified statistician. For statistical significance, p-value of less than 0.05 was considered statistically significant. IUL power calculation was done on all cases on IUL master. Initially, when 700 was not available, it was on 500. A combination of SRKT and Hoffer Q was used in 15 eyes, and subsequently the remaining 55 eyes, we had gone with the Barrett's true case based toric calculators. All cases had undergone hydrophobic single piece toric IUL. The standard phaco-dynamics were used for the MICS cases. Direct paracentral chop with the help of a 15-degree straight tip was carried out. For the flex, there was a titration of the energies for the different steps, and higher settings were taken for the corneal incisions, 2.8 into 1.4 millimeter, side port 1.2 into 1.3 millimeter, and especially in the anterior capsulotomy, after initial 2 cases, we had to raise the power substantially to avoid the tax, etc. The lens fragmentation and softening was carried out. Here again, the safety margin for the posterior capsule was raised to the 750 micron as compared to the conventional settings of the 500 microns. These are the flex machines showing the different, these are the surgical steps. Here you can see this case is a high myope who had undergone RK 30 years ago, and now she has come with such a high hyperopic changes, 34 diopter into 4.5 diopter of the cylinder. When we compare the complications between MICS and flex, the wound adhesions was the most common problem in both the groups with higher incidence, and most of these cases were of the 12 and 16 cuts. Incomplete rhexis in the 2 cases of flex were the initial cases, and later on with this experience we have raised the energy settings, and hence we got the better outcome. We compare the residual cylinders in the both right and respective in MICS and flex cases. There was a substantial decrease from the pre-operative cylinder in the cases of the flex, and again this is showing the same findings. When we compare the residual sphere between SRKT and Barrett formula, the Barrett formula has definite superiority and edge over the SRKT in the post-RK cases. Rotational stability by logically was found much superior in cases of flex because a well tensile strength and the uniform well guided rhexis given a better position of the lens. When we compare these challenges, we have found that rhexis was the major issue along with the changes in this opening in the incisions, and TrueNet formula has provided better predictability to presume the IL bar. Here the flex linked ASOCT lead to the precision in fashioning the incision, rhexis and nucleotomy. Thereby there was a least surgical manipulation over the incisions and rotating the nucleus, less energy was used. So overall in a compromised corneal, and we have got the better outcome in the flex cases with the less endothelial cell loss. In our view, the invention of newer formulas for calculating IUL power, higher and phacoemulsification machines availability and the flex have revolutionized the precision and outcome of cataract surgery in post-radial keratotomy cases. Thank you very much. Because nowadays we have the excellent qualities of the toric IULs. Their ages are, they resist well, and even in the MICS cases, it is hardly less than 5 to 7 degree rotation has taken place. And the femtorexis is, so the bag remains intact during the all movements, and there is no this tension on the rexis margins. And since it is well centralized and uniform diameter of the rexis, it gives a better stability in the toric IOLs.
Basically, because of the size of the bag in myos, because they are larger, we have a tendency to have rotation.
Yeah, that is true. That is true.
We have not seen much in this.
No.
Thank you, Dr. Prahar. So next presentation is by Dr. Deepak Megur. He'll be presenting on intraoperative hard eye during phacoemulsification and analysis.
Respected Chair, I will be speaking my sharing experience of intraoperative hard eye. It's a state of intraoperative progressive shallowing of the antechamber, propensity of the iris to prolapse out along with an hard eye during phacoemulsification, and it's a tough situation to be in. We want to report the incidence, intraoperative features, and analyze the etiologies. It's an observational case series of 4,500 consecutive phaco procedures, and we studied the intraoperative features, what stage of the surgery did the sign appear, outcomes and corrective measures. Etiology was deduced into two forms: internal issues like fluid misdirection, suprachoroidal hemorrhage, or external like a tight drape or type speculum. The intraoperative measures were taken was, apart from checking the external pressure source, defer the surgery, do IDO, B scan, IV mannitol in the OR or in the IPD, pars plana tap when it was absolutely sure that we were dealing with an aqueous misdirection, and defer the surgery. 32 eyes, 0.71% was the incidence. Fluid misdirection was the most common cause, and 2 eyes had suprachoroidal hemorrhage, which were sort of limited, and the external source of pressure, speculum pressure, was seen in minimum. In 18 eyes of fluid misdirection, we just had to wait for a few minutes for it to settle down. 2 received IV mannitol on the table. 2 eyes we had to defer the surgery for a few hours, evaluate, and then get back. 2 eyes received a pars plana tap, and then the surgery could be continued in the same setting itself. Let me take you through a few cases of different ways of management. When we began the surgery, this eye was very soft, pressure was 8. As soon as the dye was injected and the OVD was put, the eye became hard immediately in just a couple of minutes. So this was, I just did a pars plana tap. You can see the blue fluid, trypan blue letting out. The eye became soft and you could proceed with the surgery. And it was uneventful. The next case is a pseudoexfoliation. And again, the eye became hard after the nucleus emulsification, and just I couldn't proceed with the surgery. The red glow is intact. We gave IV mannitol, and after that we waited for 15 minutes. Eye softened. Then I could form the bag. I could place the lens into in the bag and then align it properly. Now, 2 had the PC tears because of the positive pressure, because of fluid misdirection. Pseudoexfoliation was the most common cause for this problem, and presence of a blue glow and fine lens dust particles in the Burgess pair were indicative. The visual outcomes were good in most situations. The problem was really with 2 eyes of suprachoroidal hemorrhage, where diagnosis was very difficult. Although a conservative approach did help because it were all limited. Let me take you through these 2 cases. A very healthy patient, perfect red glow, and now the eye becomes hard before putting the lens inside. The PCS, look at the OVD which is just gushing out, and the red glow continues to be good even at this stage. The eye is extremely hard. I can't implant the lens at this stage. I said I'll just abort. The patient was under topical anesthesia. Axial B scan by my technician showed it was normal. So I said it would be a fluid misdirection anyway. After mannitol, again the surgery is rescheduled. The situation did not improve dramatically. Somehow I could squeeze in the lens, but again the situation was worse. I couldn't align the lens. I thought because the B scan was normal, I did a pars plana tap, but nothing came out. And this was alarm for me. I just sealed the wounds, closed all the incisions, and then again, as expected, took him back to the B scan. The central scan was normal. When we do a peripheral scans, we could see these choroidal mounts with hemorrhage there. And this was an eye-opener for us. And just conservative approach did clear up, and I can be extremely lucky, I should say. Another case, eye became hard after the intraocular implantation. 1 haptic in the sulcus, and I cannot form the chamber at all. I just close it, and this is how the picture. Central scans were normal. Again, when you do the scans in the peripheral area, you could see this limited choroidal excavations and hemorrhage. And again, a conservative management over a period of maybe 45 days, eventually it settled and the patient regained. So to conclude, No, intraoperative hard eye is not very uncommon, and fluid misdirection is the most common cause. But it is not rare to have suprachoroidal hemorrhage. Only thing, diagnosis is difficult. I thought I could never have, just a matter of time. Apna time zarur aayega. That is what I learned from this series which I had. And it's very difficult to differentiate between fluid misdirection and suprachoroidal hemorrhage in the OR because good fundal glow was seen in all cases. And you can't rely on sharp pain because it's unreliable and subjective. And it's very easy to miss limited SCH if you just do an axial B scan. So because of this difficulty, we would recommend and prefer a conservative approach. There's no point in doing it in the same day. Defer the surgery, evaluate the case in detail by B scan, IDO and IOP monitor, and then only reconsider surgery for when deemed fit. Although more glamorous and and attractive, it is, I think, very futile to try to poke in a needle in a pars plana and definitely not do a limited anterior vitrectomy because we could end up having a disaster because the differentiation is so difficult. It's just about buying some time. We want to live to fight for another day. So that was the message from this paper. Thank you so much.
For the wonderful presentation.
Can you correlate one further risk factor? Age 70 plus myopic case. When AC is very deep, weak zonule, probably fluid goes through zonule.
Yes, see, for fluid misdirection, the risk factors are very clear cut. We have a loss of zonular barrier that is could be either because of pseudoexfoliation and age. This is very clear cut. But the eyes with suprachoroidal hemorrhage, which we had, they were apparently healthy. They did not have glaucoma. They were not elderly. They were between 60 to 70 years of age. One patient was 70 plus, other was 60, 65. And there was no hypertension history. But one patient, what we noticed was the first case, there was a sudden spike of blood pressure during that whole procedure. Before the surgery, blood pressure when we measured 140 by 90. During this intervention of 3 hours, which we took to the break, the blood pressure just shot up. For it and persisted for 1 or 2 days. So intraoperative rise in pressure, blood pressure, for some reason we don't know, that was one of the risk factors for that particular case. And preoperatively her blood pressures were normal. And both the pressures were not known case of glaucoma or ocular hypertension, nothing. They're absolutely routine cases. The point here is limited suprachoroidal hemorrhage often can go undetected because we're doing a closed chamber procedure. It can happen somewhere periphery, we can't detect it. And every intraoperative eye need not be a fluid misdirection. So it is not wise to just poke in and try to be heroic and do an anti-vitrectomy, and it could be disastrous in some times. That's the message.
Wonderful presentation. The take-home message is never to poke, wait for some time, and then proceed. Thank you. Thank you very much.
Thank you, Dr. Mikur. So the last call for Dr. Dev Prasad Gopal. He is not there, marked absent. Dr.
Manpreet Kaur hai. Last one.
Tejashwi Ragulu, marked absent. Dr. Rajendra Prasad, absent. Okay. Yeah. So next we invite Dr. Manpreet Kaur to present the paper on long-term assessment of PCIOL optic adherence and anti-YAG capsulotomy rate of surface-modified IOL. This was the AIOS Anti-Vision Award of last year, I think.
Yes.
Yeah. Congratulations at first for the award.
So, very good morning to all of you. I'll be presenting our research on long-term assessment of posterior capsule IOL optic adherence and its impact on the Nd:YAG capsulotomy rate after implantation of a hydrophobic acrylic IOL with ozone surface modification. There are no financial disclosures. So, various techniques of intraocular lens surface modifications have been described over the years: surface coating, covalent grafting, etc. The main aim has been to enhance the biocompatibility of the material and lead to a significant decrease in the incidence of posterior capsular opacification. So, a new aspheric hydrophobic acrylic IOL with posterior surface modification was introduced a couple of years back with UV ozone treatment modification. The mechanism proposed was that there is an increased adhesion of fibronectin and less epithelial cells to the posterior IOL surface, which promotes IOL adhesion to the posterior lens capsule and prevents PCO. So what we aim to study was the PC and IL optic adherence in surface modified ILs and its impact on the NDR capsulotomy rate and visual quality. A prospective interventional study of 93 eyes with IMSC was conducted at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. All cases were implanted with the hydrophobic acrylic IL with posterior surface ozone treatment, and cases with any comorbidities were excluded. The primary outcome measure was the posterior capsule adhesion to the IL optic and ASOCT and the NDR capsulotomy rate. Secondary outcome measures were visual quality assessed using ray trace aberrometry. Follow-up was performed on post-operative day 1, 1 and 2 years. So these are the demographic details. No case had any intraoperative posterior capsular rent or vitreous loss, and at 2 years, 94.6% had a corrected distance visual acuity of 20/20 or better, and 100% had a corrected distance visual acuity of 20/32 or better. So complete PC to optic adhesion at 2 years was observed in cases that had an initial smooth PC configuration. So this is the day 1 ASOCT, in which you can see there's 497 microns of fluid between the IL optic and the posterior capsule. At 1 year, it reduced to 80 microns of fluid, and at 2 years, there was a complete PC and IL optic adhesion. In cases with a wavy initial PC configuration, there was a persistent PC optic in adhesion at 2 years. So as you can see in this case, even at 2 years, 96 microns of fluid persisted. So 2.9% cases had a complete PC optic adhesion on post-operative day 1. At 1 year, the figure increased to 67.6%, and 2 years, nearly 3/4 of patients had a complete PC optic adhesion. So Zhu et al. Had earlier evaluated PC optic adhesion in visual axis after phaco. They observed 41.5% cases only to have a in adhesion at 1 day and 7.1% at 2 months. However, why did they observe such a low incidence of persistent in adhesion? One, the IL used, of course, was different, and they used sheen plug imaging, which is much less sensitive than ASOCT in picking up these residual microns of fluid. It may have grossly underestimated the PC optic in adhesion. Except for this, there's no other study that has tackled this topic. Visual quality at 2 years. The residual PC optic distance positively correlated with total higher order aberration. So the more the PC optic in adhesion, the worse the visual quality. So posterior capsular opacification developed in 7.5% cases as 2 years, and no PCO in 92.5%. Of these, 85.7% cases had persistent PC optic non-adhesion. So non-adhesion was a risk factor for PCO development. NDR capsulotomy was needed in 3.2%, and all cases requiring a YAC cap had persistent PC optic non-adhesion. So we conclusively concluded that inadhesion was related to a higher rate of NDR cap. So just to conclude, surface modified ILs are expected to have higher rates of PC optic adhesion with less PCO. Nearly 2/3 cases at 1 year and 3/4 cases at 2 years have complete PC optic adhesion. Complete PC optic adhesion correlates with a superior visual quality, less PCO, and no NDR glazer capsulotomy. This was the first study to characterize the PC optic adhesion using a high definition ASOCT in a surface modified hydrophobic acrylic IL. Thank you for a patient hearing.
Thank you. It was indeed a wonderful presentation. Thank you.
From the audience for any presenter?
Yeah.
So with this, we have come to the end of this competition paper, Cataract session. And thank you to all the presenters. Thank you very much.
So we'll have a group photograph of all the presentees. So I request everyone to please come on the dais.